Hello, my name is Dr. Shahbaz Ansari. I have recently cleared my PLAB 2 exam on the 5th of March. And as of now, I am a GMC registered doctor and waiting for my NHS journey to begin. And all of these sessions, all of these videos, all of these conversations are basically to help my fellow doctors who are actually thinking or who are in the way to pursue their NHS career. So yeah, this session will be regarding counseling and regarding ethics. Concerning the PLAB 2 exam, which consists of 16 working stations, so you might as well get around 5 or 6 stations, which will be actually counseling. And as far as ethics is concerned, the likeliness of getting an ethical station, which is purely ethics, it's very unlikely. But the thing is that you cannot basically differentiate, or you cannot actually separate ethics from counseling or medicine. So every station that you have, be it history taking, be it counseling, be it telephonic consultation, be it even the examinations and the SEMMAN, ethics cannot be separated from medicine, and every part of medicine does have some ethics into it. It might be related to your IPS, it might be related to your clinical practice. So yeah, if you have good ethics, you can actually, it will actually help you in your history taking stations as well as your counseling stations. So I'll be touching every part one by one, and if you have any questions, you might as well drop a message in the chat box. So I will be able to answer them accordingly. And the people who would want to volunteer regarding, I've got two scenarios. If you want to volunteer, if you want to practice online, yes, just please suggest your name or raise your hand, so I would be able to just allow you accordingly. So concerning, let's come to counseling station once and for all. So in counseling stations, the diagnosis has already been made. Whatever you basically have to achieve by the history taking station is basically you have to make a diagnosis, and then you have to manage the case accordingly. Be it in MI, be it pneumonia, be it TB, be it whatever the case is. In counseling stations, the diagnosis most of the time has already been made. The diagnosis of pneumonia would have been made, the diagnosis of hypertension would have been made, or diabetes, or it might be basically lab investigations already been done, and now you have got the lab investigations, you might as well get a small history. So whatever you want to gain from this conversation will be basically the understanding of the patient of why he got it done, and all of the big questions, all of the with the maftosa thing, it's very less of a value here because the diagnosis has already been made. And as in FY2, what kind of a questions will you ask that will actually change the diagnosis? As far as I have my knowledge, the question that you should ask in these scenarios should be the ones which will help you during the management. Like for example, if a person if lab investigations have been given that an XYZ person came to the hospital and got done these investigations, now call him and tell him these labs and counsel accordingly. So basically all of the relevant information is been given, and you just have to ask, okay, what was the understanding of the patient when he came in, why he got these results done, and what might be the reason behind the examination and the results. For example, if a patient comes in the clinic and he had an LFT, a routine blood investigations done, and now you have got the investigations, and they're saying that AST is elevated, ALT is elevated, and you've got another investigation, MCV is elevated. So these are all the related findings of an alcoholic liver disease. There might be a reason behind it, which might be alcohol related or might be a liver disease. And these are only mildly raised. So you just call the person and ask, could you please tell me why did you get these? He's like, oh no, I just got them because it was a routine blood investigations and blah, blah. And then you take a history. Okay, he is an alcoholic. So you have to counsel him regarding his alcohol issues. And whatever you ask, it's not going to change not going to change the diagnosis. even if you ask anything, you have got the lab investigations, right? So you have to counsel accordingly. And in these scenarios, since the diagnosis has already been made and the major work is done, so you'll be putting more emphasis on the management. And in these scenario, the doctor, you being the person, will have to talk a lot rather than the patient. Because if it was a history taking station, there you ask the questions and the patient will be the person who does more of the talking, because he's actually giving you information, right? But in counseling stations, you already have most of the information which is required in order to manage the condition. So you are the person who is going to be talking more and more. And that is the very reason, since you have to do more of the talking, be it explaining what it is, what kind of investigations will you do, what kind of examinations will you do in order to confirm the diagnosis, and what will be the management plan, which will be lifestyle modification, which will be the acute medication that you want to give or would like to give, or the referrals, or the putting on follow-ups, or doing safety netting. And even after that, if you have got time, you might as well ask them, okay, I'm going to give you some leaflets in order to answer all of the questions that you might have, or you can always come back to us. So these are all the postulates that you need to tick in a station which is counseling. And in counseling, the doctor is the person who does most of the talking. So yeah, that is the reason, the emphasis, the breakdown of the time management in the counseling stations should be, which is advised by me, and it's a scenario, it's a condition which is actually tested by me. Because in the counseling stations, most of the questions are being answered, and you will be given all the information in the question or in the scenario itself. So why would you waste your time and ask a detailed history where all the things are given to you on the scenario itself? So yeah, it makes sense. So that is the reason the breakdown of the time in the counseling stations should be that it's an 8 minute station, right? So you should abstain, you should actually keep 3 to 4 minutes for the history taking, where you will do everything. You'll introduce yourself, you'll ask the history, okay, and the you have to be a bit cheeky in a sense that you have to ask the right questions. You have to open up with open-ended questions in order to gain more and more information, right? I'll be explaining this when I'll give you a scenario, and you'll have a better understanding when I'll do an actual station. So yes, so the scenario, the history taking should be more or less 3 to 4 minutes. So you gain all the information which you can actually incorporate in the management part, and rest of the time, which is 4 to 5 minutes, should be actually spent on management, because in counseling stations, management is more important. So yeah, this is the thing. And Is history taking format the same as taught us here in Pakistan or different? Well, history taking format is more or less the same in everywhere in the world. The only difference that you have, the ethical scenarios and ethical values being practiced in the UK, where in UK, whatever history you take, whatever management you do, it's basically patient centric. So whatever you speak, you basically ask, you offer, okay, in a very nice and humble way. But in Pakistan or in other subcontinentals, this is the session which is I'm giving you a very Pakistani scenario. So in our countries, we have got so much patient influx that we cannot actually do a patient centric approach. So yeah, that's a bit unfortunate. So yeah, the difference is the history taking is more or less similar, but in UK, it's more of a patient-centric approach. You do not tell them to do anything. You basically offer. You basically ask them and convince them. So yeah, that's the difference. So far, am I clear? Was it too much information that I dropped like that? Just give me a thumbs up if any questions that you have. Feedback is really good. Should be good. So I can just amend myself and change according to the perspective of people. So yeah, this is the counseling thing. And after that, coming to ethics. Well, ethics in UK is really important because, as I said earlier, it's all patient centric approach, because it's the consumer is the patient and you're the provider, right? So everything will be done according to the patient's needs, according to the patient's will. If they want, if it's a life-saving procedure and if they say no, you try to convince them, you try to assess their mental capacity, and even after that they say no, you just raise your hand. That's all. If they don't want anything, you're not supposed to forcefully provide them. If they come with an alcohol addiction, and then you ask them, would you like me to counsel you regarding alcohol cessation? And if they say no, I don't want to, I'm not ready, well, that's absolutely fine. Whenever you're ready, Mr. Whatsoever, we'll be able to help you out whenever you're ready. So these are the ethical values, these are the ethical scenarios, which I'll actually help you in every station, be it a history taking station, be it a counseling station, be it an examination or a semman. And if you people actually incorporate good ethical values in the exam and in the actual clinical skills, it will actually help you out in your clinical practice as well. And it's not basically just concerned with the PLAB 2 exam. You should actually have good ethical values if you want to become a doctor and work in the NHS, because by the end of the day, ethics is really important. So yeah, so the depiction of the time should be in the counseling station 3 to 4 minutes of history taking, which should be a very brief history, and you need to ask open-ended questions so you could gain more and more. And rest of the whatever information that you gather should be the information which will help you out during the management part, where you will be the person who does most of the speaking. So yeah, and 4 to 5 minutes is for the management. And talking about a shorter history, it's actually easier said than done, because a lot of time doctors are actually so stuck with a particular pattern of history taking that they actually cram it, they memorize it in a certain way, that they actually have to ask every bit of a question. Even if the patient tells you everything, they need to hear that particular statement in a particular manner, in the particular pattern. So that actually wastes time. And one advice, if you would ask me, that you should have a roadmap, you should have a good approach, but your approach should not be hard and fast. Your approach, your roadmap should be a bit of a flexible, and you should have the window of any alteration, any appropriate changes, if it is needed according to scenario. So you should not be hard and fast. Yeah, how do we improve history taking approach? Any suggestions on how to not waste time? Well, that's what I wanted to tell you, that you should ask more open-ended questions. Um, well, I'll be able to, what do you call it, explain this if I get a volunteer who would want to practice a station, or you just want me to do all of the talking by myself. If anybody wants to volunteer, it'll be really good, and it'll actually make you a bit more clear in your doubts. If anyone wants to volunteer, I've got two scenarios, one for ethics and one for counseling, which are actually the scenarios which I got in my exam. Anybody? Well, I think nobody is interested in practicing, so yeah, it's absolutely fine, because there is a bit of okay. That's good, Dr. Lakshmi. Well, you, kudos to you. You actually surpassed the confidence thing. So yeah, that's really good. If you
Thank you.
like to just turn off on your audio so I can listen you.
Yeah, I have switched on. Am I audible?
Yes, you're absolutely audible. How are you, Dr. Kamar?
I'm fine. How are you?
Yeah, I'm amazing. So,
Okay.
Kudos to you that you actually volunteered, because this is the actually this is the first part of being a doctor in the NHS, that you have to have confidence in order to sit in the PLAB 2 exam, because this is the thing that you'll be doing
Okay.
for 16 times back to back.
Yeah.
So
Yeah.
let me just give you the scenario so you'll have a better understanding. So can you see this? Can you see this, doctor?
Yeah.
Okay. So this is kind of a scenario which you will get when you'll be outside the cubicle. So the scenario says that a 36-year-old male was admitted with MI last week. He underwent an angioplasty and a stent was placed. Now he's being discharged on aspirin, clopidogrel, captopril, and bisoprolol. Please make sure that he is clinically stable to be discharged and given appropriate management. Special note, none. So this is a kind of actual counseling scenario. You're the FI2 doctor on duty, and you get this patient who is admitted for MI last week. So the procedures were done, and now he is good to be discharged, and these are the medications. So yeah, you will be the person who is going to assess if he is clinically stable or not. So
Okay.
how are you going to approach this patient?
Okay. Uh, should I start with the proper format?
Yes,
Like we do the station. Okay.
yes, I'm just going to give you.
Hello.
Yeah, just wait a second. I'm going to start the timer.
Okay.
Okay. So yeah, start.
Hello.
Hello.
I'm Dr. Lakshmi. I'm one of the junior doctors working here in the A&E. Could you please confirm your name and age for me?
Yes, doctor. My name is James, and I'm 36 years old.
Okay. How may I address you?
James is fine.
Okay, James. So I understand that you had been admitted last week for MI and you had some procedures. So how are you feeling right now?
Oh yes, doctor. I'm feeling much better. Thank you for asking.
Okay. So are you having any sort of complaints right now?
What kind of complaints are you talking, doctor?
Any chest pain or are you having any pain in your chest?
No, no, doctor. No chest pains. No.
Okay. So you're feeling fine.
Oh yes, doctor.
Okay. Uh, I don't know. What should I ask?
It's counseling. Counseling.
Okay. Would you please help me? I'm not able to
That's
think of anything.
It's absolutely fine.
Sorry.
So no problem, no problem. So these kind of scenarios will be like, so this patient was admitted for MI, right? And the
Yeah.
underwent the angioplasty, stent was placed, and blah blah medications. Now you have to discharge him basically, and in order to discharge, you have to make sure that right now his condition is stable to be discharged. So your approach should be, your introduction was really good, but whenever you get a monosyllable name, which is James, so there is no other way to address this patient, right? So it's better to just address it. Hello,
Right.
James. Yeah. Could you please confirm me your age, and you introduce yourself, and that's all. Then after that, did you just ask that? Okay, how are you feeling, James? Yes, doctor, I'm feeling good. Could you please give me a recap of why, what actually you admitted? I can see from my notes that you were admitted for a condition. Could you please give me a bit brief of a history or a short recap? Then I'll tell you, "Oh, doctor, I had a chest pain for which I was hospitalized, and I had this complaint, and I underwent." So when you ask this kind of a question, could you please give me a brief recap of what happened and why did you come to the hospital at the first place? So he'll actually vomit out all of the information, because he being
Okay.
an actor, he being a patient, he wants to be listened, right? So if you ask me the right question, I will give you the detailed answer. And after that, now you basically have the history that okay, he had an MI. So you have to make sure that okay, He might be having symptoms like this, like that right now. Okay, are you having a chest pain? Are you having a shortness of breath? Do you have any other signs and symptoms which you had faced earlier? Oh no, that's actually good. And then you ask a very brief history. Okay, I'm going to ask you some questions regarding your medical history and regarding your lifestyle in order to counsel you in a better way, as I'm here to assess you in order to discharge you, because it's actually your task that please make sure he's clinically stable to be discharged and given appropriate management. Okay, so that's the appropriate scenario where you ask medical history, medical allergies, family history, all that sort of things. And after that, you have to in the rest of the history, you basically have to ask questions that you could incorporate for the management part, that what kind of a lifestyle advice do you need to do, what kind of a lifestyle advice you need to give. Maybe he smokes, maybe he drinks alcohol, maybe he's not physically active, maybe he has a stressful job, maybe his diet is very poor, maybe he does not take care of himself. So these are the questions that will help you out in the management part. Okay, so this kind of history will actually help you in order to give you sufficient amount of information which can be used by you when you're counseling the patient in the lifestyle modification. And then you just basically take a brief history, then you explain, okay, you had an MI, but from the history that you have given me right now, you seem absolutely stable. And we're going to give you some medications. Are you being briefed? Have you been briefed on the medication that you will be given on discharge? So you're assessing, okay, does he know about the medication? Then most of the times he will say, oh yes doctor, the consultant actually told me about the medication. So you're barred away from this kind of a text, that you don't have to explain the medication. And this you will only know if you ask the patient, okay, since you're being discharged, are you aware of the medication that you'll be given on discharge? So if he says no, then you explain the medication. If he says yes, then you ask, oh, do you want me to explain the medication again? Oh no, doctor, that's absolutely fine. So what is left is just the lifestyle modification, the lifestyle counseling, as well as the advice that you need to take. It's really good that you happen to be aware of the medication. I would advise you that you take your medications accordingly. Then you give lifestyle modification, then you advise, since this is a very big change in your life, and so therefore we will put you on follow-ups, and make sure that everything's fine by checking your progress, and if there is any altercation needed to be made in your medication or any other therapy. And after that, since you have done that, since you have counseled about the medication, counseled about the lifestyle modification follow-ups, then you also have to do the red flags, that okay, since you have an MI, and by any chance if you happen to have any chest pain, any shortness of breath, of or any other symptoms that you have had earlier, it's best to come back to us. And simple, in order to make sure that everything's fine, I'm also going to ask my senior to review you as well. So yeah, and that's where everything ends. And most of the times the investigations and the examinations will be given. If it's not mentioned, it's better to just verbalize one statement, that thank you for the history, and in order to make sure everything's fine, I'm going to quickly examine you, which will include a general physical examination, taking your vitals, and doing a chest examination in order to make sure everything is fine. And I would like to order a panel of investigation, which will include routine blood investigation, an ECG, a chest X-ray, and blah blah. That's all, because in the counseling stations it's very unlikely to get a finding, because all the diagnosis is made. So from the scenario that I gave you, is there any new thing that you are suspecting from your history that you ask? You're basically picking out all the relevant information which you can actually incorporate in your management. You would counsel a patient of smoking if you only know that he is smoking. If you want to counsel a patient regarding a healthy diet, you would only counsel them if you would know that he is on a bad diet, if he needs to change his diet. If you just start counseling him, you should not smoke, and he would reply, oh doctor, I do not smoke. So that's a bit of a tricky situation, so you have to act accordingly and according to the scenario. that do we need to say this, do we need to say that, and the kind of history that you need to take in this scenario is very brief. So I'm already admitted, I'm already been treated, I'm being discharged. So what kind of a new information as an FY2 will you be asking from me? So yeah, is it understandable, doctor?
Yeah, I had a question.
Yeah, please do.
Supposingly, if we say him that, could you please tell me what happened in the first place? Can he like the patient say, it's already written in my notes, doctor? Can't you just read? And why are you asking me?
It's very even if you
Can
get,
it be a possibility?
yes, it is a possibility, but being this is a simulated kind of a scenario, it's very unlikely that you get this kind of a rude patient. And even if he says that, it's absolutely
Okay.
fine. For example, if you transfer as a doctor one patient to the other doctor, still, and the doctor tells you the examination findings, still you do your own examination in order to make sure everything's fine, right? You don't blindly trust another person's notes. Simple. This is a good
Right.
response that you can give. Or I can see that you're being your history is being taken, but
Okay.
as I am in the doctor right, I'm just making sure everything's fine. You don't actually blindly trust the other
Okay.
person's findings or another person's review, right? You have to make your own approach. You have to make your own review.
Right.
So yeah, doable.
Thank you. Thank you. Yeah.
Okay. If anybody else wants to try an ethical scenario, because this session was going to end by the end of 8 minutes, or I should just go in with Dr. Lakshmi here. Anybody else wants to volunteer? Uh, I think Dr. Lakshmi, you're stuck with me if you want to.
Yeah. Yeah. Sure.
Okay. So the other kind of the other scenario that I had was this one, that Andrew has come to meet you as you're an FI2 doctor at GP clinic regarding some concerns about her daughter Sandra, who is 33-year-old. Sandra is diagnosed case of depression and is currently on antidepressants. She's struggling with finances and she has quit her job recently. She has not told her father regarding her condition. Please address the father's concerns and deal appropriately. Special note, none. So this is the scenario which I got in my exam, and this is a whole and soul ethics kind of a scenario. So what do you think you have to do here? You would like to do it?
Okay. I can try.
Okay. So yeah, we've got only 6 minutes 30 seconds, so we'll just quickly do it. Okay.
Okay.
Okay. Yeah. Start.
Um, so, hello.
Hello.
I'm Dr. Lakshmi. I'm one of the junior doctors working here in the GP clinic. Could you please confirm your name?
Oh yes, doctor. My name is Andrew, and
Okay, Andrew.
yeah, I'm here to just ask how is my daughter Sandra doing?
Okay, sure, Andrew. I'll be telling you everything about her. So, could you please tell me what all? Why did Sandra come to the hospital in the first place?
Oh, well, doctor, she's basically diagnosed with depression, and she's on antidepressants. And recently, I've just come to know that she's actually struggling with her finances, and recently she quit her job. I just wanted to confirm whether it's the case because she's my only daughter, and I'm really concerned about her.
Um, I completely understand, Andrew. I understand your concern. Uh, of course, as a father, it must be difficult for you to see your child having this sort of medical condition. So, before we can go any further, could I ask you a few more questions so that I can have a better picture of your daughter?
Yeah, sure, doctor.
Okay. So, uh, th- is your daughter feeling any thoughts of she might have talked to you, any feelings of worthlessness or hopelessness?
No, doctor, it's just that I've not met my daughter for a couple of weeks now, and I just wanted to confirm that how is whatever I say, is it the actual reality? Because I want to help her out regarding her finances.
Okay. Okay. And has she ever tried to harm herself or try to commit suicide?
Well, I'm not aware of that, doctor. Could you please just confirm that is she depressed? Is she on antidepressant? Is her antidepressants working?
I understand, Andrew. Definitely, we have we cannot share any information regarding a patient to anyone, even if you are his parent and you are really concerned about her. It's this that we doctors in our medical fraternity, we are bound by certain legal guidelines, due to which we cannot disclose any information regarding a patient to
She's
anyone without their permission.
She's my daughter, doctor, and I'm aware that she's diagnosed with depression as I have brought her to the GP clinic multiple times myself. So, if you're concerned about that, so rest assured, I am aware of her condition. I just need to confirm that is her antidepressants working, and has she quit her job?
I really understand, Andrew, your concern, and as a parent, it is quite difficult for you. But will you just tell me, has Sandra ever talked to you about her complaints or anything she's feeling?
No, doctor. It's just that I've brought her to the GP clinic multiple times. So yeah, I'm aware.
Okay, has she ever talked to you about her about what she feels about it, and if she's having depression, has she ever told you about it?
No, doctor. It's just that I do not talk to my daughter a lot because I do respect her privacy. So yeah.
Okay, so may I know from where did you come to know that she's having depression and she's taking any medication for it?
So you are telling me that she is depressed, right?
No, trying to know whether you're saying it and that you want to her. Has anyone told you except her that she's having this condition or she's on any kind of treatment?
No, doctor. I am aware of it.
Okay. Uh, has she talked about it to your mother or any other family members?
No,
To
doctor.
her mother?
I know, doctor. You just tell me, and we should just let it go.
Okay. Uh, I understand, Andrew, but I'm really very sorry. I'm being a medical professional. We have certain rules that are set by a regulatory body, the General Medical Council, according to which we cannot
Sorry, doctor.
disclose any.
Really sorry, but I've got less than 1 minute. But this is the whole scenario that we are actually talking about the confidentiality. You're not supposed to say anything, and you have to just evaluate. Okay, how did you come to know? What do you know about it? But I would advise you to take a bit of a history
Okay.
and make a roadmap of your own, so
Okay.
you can actually not allow the person to steer you according to their will. And you should be the person who should have the steering wheel and not the person, because the patient will actually want to steer you in his direction. But since you are being assessed, so you would should have the ability to ask for any information from that scenario. So yeah, it was really nice talking to you people. And if you have got any questions, you can always drop in a text in the group. And yeah, see you in the next session. And I'll be